Hi, everybody, and welcome to a Prasiska GI Cancer-Focused Tumor Board. My name is Sam Klepner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, and I'll go around as I see it on my screen. So I'll start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm an abdominal radiologist at the Malignant Institute of Radiology at Washington University in St. Louis.
Hi, everyone. I'm Pritesh Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University in Atlanta.
Hi, I'm Marty Weiser. I'm a colorectal surgical oncologist at Memorial Sloan Kettering Cancer Center in New York.
Hi, I'm Al Benson, and I'm a GI medical oncologist at Northwestern University in Chicago.
High-level detail, this is a 76-year-old woman with an incidentally discovered gastric mass, biopsy of a submucosal lesion favoring a mucinous neoplasm, taken to an upfront surgery, partial gastrectomy with a gastroj and celiac lymphadenectomy. Final pathology, unfortunately, upstaged to a pT4aN3aM1 mucinous adenocarcinoma with a positive margin and multiple tumor deposits in the stomach and metastatic deposits in the omentum. The available molecular testing is a microsatellite stable tumor. And the question is, what adjuvant, or I might tweak this, what systemic therapy should be considered for this patient? So just to walk through the history, this was an incidentally discovered mass on a scan for kidney stones in an otherwise what looks to be a healthy patient with a history of hypertension, reflux, Crohn's disease, a resected melanoma, no drug or alcohol history, and no family history. So here we're about to see the initial presentation CT scan. The description of the findings is here, but I will let Dr. Siegel elaborate on the available imaging here.
So we have two axial images. The image on the left shows a predominantly cystic mass along the greater curve of the stomach at the level of the antrum with a focus of calcification. And then if you look along the greater curvature of the rest of the stomach, there's some small punctate peritoneal nodules. If we go to the image on the right, the same mass looks a little different here. It's a little bit more thick-walled and has more sort of an undulated, thick-walled periphery with a cystic center, and again, a focus of calcification, and a small soft tissue deposit on the anterior aspect of the antrum along the lesser curve. Just looking at these images, I don't think we would be able to confidently say this is a mucinous tumor. It's unusual for gastric tumors to have areas of calcification, but they are most often seen in mucinous tumors. But other things in the differential would include a cystic GIST tumor, a cystic neuroendocrine tumor, a metastases, and even some sort of weird fluid collection related to pancreatitis. But with the soft tissue deposits along the greater curve and the soft tissue deposit anterior to the antrum, our suspicion for a malignant option would be the highest.
Yeah, and hindsight is 2020, and of course every case is different. This patient went to an upfront surgery, but if you had seen this available imaging, would you have some concern of more than just a incidental localized cancer?
Maybe. I mean, I also don't have all the images. Certainly, the deposit on the lesser curve of the stomach on the antrum makes me suspicious that there might be more, because that deposit there looks like it's at least a centimeter. So maybe it's hard to answer it, and sometimes it's difficult to tell whether we're dealing with tiny peritoneal deposits or not. One of the ways that we can really do a much better job discriminating tiny peritoneal deposits from something else is MR with diffusion, because these pop up like light bulbs on our diffusion imaging. So sometimes that will be very helpful in looking for either localized or even small scale peritoneal disease, the diffusion imaging on an MR. But here, no, it's difficult to say.
Yeah, I completely. Our abdominal imaging team often weighs in, and they have the research study of MR PET to try to even further perhaps adjudicate some of these equivocal findings. All right, let's move on. So the patient was taken to an upfront surgery, a partial gastrectomy, as I said, with a gastro-J celiac lymph node dissection. The pathology is shown here. It was a 7.5 centimeter mucinous adenocarcinoma. Tumor involved the distal stomach and duodenum, invading the serosa. There was extensive perineural invasion extending to the distal and radial margins. No nodes were positive, but multiple tumor deposits were present in the greater and lesser omentum. And this was therefore staged as a T4aN3aM1 microsatellite stable tumor. We don't have the initial thinking around upfront surgery versus consideration of perioperative therapy, perhaps, but certainly every case is different, and we've all had many cases that are pathologically upstaged at the time of surgery. So the question here is, what additional therapy should be considered? And I'll start with Dr. Benson. How would you sort of think through this case in terms of, would you counsel this patient as a metastatic disease, and how would you approach the therapy?
I think the implication might be from the pathologic report that this patient had resection of all macro disease. And that's just a matter of semantics, I think, in terms of postoperative therapy, because adjuvant therapy, by definition, means that you're treating presumed microscopic disease after complete surgical resection. Nonetheless, this patient is at certain risk of recurrence, and perhaps rapidly, given the extent of her metastatic disease. And therefore, I would view this patient as one with metastatic disease and who should be treated with a metastatic regimen. And I would think that a regimen such as FOLFOX would be very appropriate for this individual.
Yeah, I agree. We certainly have the classic trial to support that, although patients were R0 in that study. I'll ask Dr. Patel and Dr. Weiser two versions of the same question. Is one, is there ever any role to go back in and try to operate to clear a margin? And two, in patients who have R1 resections, do you think about radiation after, say, a course of systemic chemotherapy? So I'll start with Dr. Weiser.
Yeah, I think it would be very tough to figure out exactly what margin you are going after. In this particular case, I think there's risk for recurrence and multi-site. So I wouldn't offer them reoperation. I think in this disease, it's unlikely to be successful, just added morbidity.
Totally agree. Dr. Patel, what do you think about radiation in the presence of R1 gastric cancer surgeries?
Yeah, I think you alluded to perioperative therapy, which is typically our practice for CWER 2 and 3 and true gastric cancers. In a situation like this, where we're now in the adjuvant setting without having any neoadjuvant therapy, one of the indications where we might consider radiation after an appropriate course of systemic therapy would be potentially an R1 resection like this. A few things here, though, give me pause. I mean, the locally advanced disease, the tumor deposits, and the low-grade mucinous histology sometimes felt to be somewhat radioresistant. So those features in this case, I think, give me some pause. But if the patient were to have tolerated a full course of systemic therapy with negative restaging scans, or at least restaging scans with no evidence of metastatic progression, I think it would be a reasonable conversation to have with the patient. And we're very upfront about the fact that these are typically large radiation portals where we're covering, multiple lymph node areas within the abdomen, and there's toxicity associated with that. So Not everyone's going to be a candidate for this when the time comes, even in those cases where we want to offer it. So important to have that conversation with patients. But in an R1 case, I think we probably would have that conversation.
Yeah, I agree. I think we think through very similarly. I'll go back to Dr. Benson for one version of the regimen. So in light of the recent frontline chemo and IO approvals, and again, we don't know the PD-L1 status of this patient. We do know the patient has a history of Crohn's. We don't know the details. Would you have caution or reservations about considering PD-1 along with FOLFOX?
I think that's a very appropriate consideration. As an aside, it is important for such a patient that we know HER2 status, PD-L1 status, MSI status, in making that decision. But I do think the combination is a very appropriate consideration.
Yeah, I would completely agree. I think biomarker testing should be emphasized in any potentially metastatic patient, and it is really definitely critical. We're getting better and better about tailoring therapy to biomarkers in this disease, which is great.